the timeline to get a perspective of why and how this epidemic also spreads. So suppose if you and I got exposed today, we would feel perfectly fine for the next 2, 3, 4 days, maybe. About the 4th, 5th day, fever, cough, shortness of breath. And then it takes a couple of days of that going on before one gets tested. And then the results comes back in 24 to 48 hours. And that's when one gets diagnosed. And then the health department and others are notified. And we become contagious, in fact, a couple of days before we even develop symptoms. And that's where the problem lies at, is individuals who don't have symptoms, who are asymptomatic or pre-symptomatic, are transmitting the virus and creating a larger pool. So it would have been easy if someone got sick and at that time they were transmitting, because when you begin to feel sick, you come home, you lie down in bed and you stay at home. But at this stage, people are feeling fine and then they're transmitting the virus. And that's what's propelling the epidemic. The fever and all comes on the day 5 to day 12 and those. This is for someone who's at home and stays at home without any complications. The problem is when patients are developing complications. And same thing in terms of they get exposed on day 0, by day 5, they begin symptoms, but it takes a couple of weeks, 2 weeks, before they begin to have complications of shortness of breath. Actually, there are 2 syndromes that are happening in ways. The early is the viremic phase, that the virus is in your system, which is the onset of symptoms here. This is more a immune complex phase. This is where your immune system overreacts, and what we call is a situation where you begin to have ARDS and then patients often get admitted to the ICU. Let's take a minute and let's look at the pyramid, because what we know is there are lots of people who have the COVID infection, but in fact, they may not show symptoms. So if you look at some basic data, that if we have 1,000 people who presented with a flu-like illness, but even to go back a step, if you have 1,000 people who have the COVID infection, only about 20 of them are going to present signs, 200 or 20% will show signs and symptoms. So what we need to know is there are many who are asymptomatic, but that could still be spreading it. But if we look at people who are presenting with a flu-like illness, 1,000 of them, 10% will turn out to be COVID. If you then follow those 100 COVID patients, 15 of them will become hospitalized. 7 of those, that 100, will then go to the ICU. 3 will be on the ventilator, and maybe 1 to 2 will die. So the mortality rate of those who present with a flu-like illness, it's nearly 1 to 2% that we are finding. Extremely high mortality rate, like I talked about with the flu, it's a much lower mortality rate. When we looked at those numbers early on, for our capacity, the answer was, we'll need maybe 2 times the number of beds that we have, 3 times the number of ventilators, 4 times the number of ICU beds. However, this is the situation in New York. We have, for the most part, averted that disaster. And I'll share with you how and why. And here's why and how we have done it. This is what happens in a normal epidemic curve. That's when we have initial cases and then a surge occurs. That's when we have an excessive number of cases and then the epidemic dies out because most of the people have become infected over time. Well, what we have done is dampen the curve. This is what people have talked about. We want to dampen the curve. You flatten the curve. And what we did was, in effect, caused the surge to be, the peak to be dampened significantly lower, but we have dragged it on a little bit longer. And what we have done is maintained our capacity of the healthcare system so that we can treat individuals who are sick and not get overwhelmed. And that's the main reason for doing what we did, which was social distancing. Share you a real example of what happened in 1918, Philadelphia and St. Louis. What happened was, in Philadelphia, they waited nearly 2.5 weeks before social distancing was undertaken. St. Louis took on nearly 2 days after the first case when they did social distancing. You can look at the number of deaths per 100,000 in between the two cities. Now, I'll tell you this, this was a second bump. And the reason this occurred was, which is what we call the second wave. If you quit social distancing too early, you get the threat of having the second wave. And so this is a real live example of the same things that we are going through at present. There are ways to compare our social distancing to other cities and communities. This is from unicast.com, which looks at data through cell phone interaction. People have their cell phones, and the cell phones do radio waves with one another, and this can tell where there are groups of people merging and where they're congregating. And also with University of Memphis, we have an app, and if you have an Android phone, today you can go to the website mcontain.org and download the app. And if you have an iOS and iPhone, within a few days, that app will be available, and it allows you to see your crowding alerts, encounter numbers, how many times you were close to somebody, or being within 6 feet. And also, if the person authorizes and a health system authorizes, there's an option for the COVID-19 alert as well if you've been in contact with someone with COVID-19. This was developed right here at University of Memphis. So how do we prevent the COVID virus from causing us the high mortality rate and spreading and creating a huge problem for us? And the best initial measure is social distancing. Basically, if I am home alone, I have no social contacts. My proximity encounter is 0. With a family of 4, it's 3. At work, may reach up to 10. But this is where we get into problems. At social gatherings, we may be at 25 or more. At mass gatherings, so to give you an example, Mardi Gras, that was an absolute disaster. Our first 2 cases came after they had been to Mardi Gras, and it seeded numerous areas in our county as well as in our state. Social distancing prevents the virus. In fact, it starves the virus because the virus feeds on our social interactions. So that's where social distancing can actually starve the virus. And then I'll finish up. You're probably asking the single most important question, which is, what is our end game with COVID-19? So in brief, it begins with the social distancing, which is a blunt tool, and it works to stop the virus from spreading to many people. It goes to mitigation, from we're not able to contain it, so we go to a broader scope, which is mitigation. but then we have to go back to trying to contain it. Social distancing, then comes testing, and more testing. I can talk more about that. Contact tracing, isolation, surveillance, and vaccine. And so here's a graphic, which I think is probably the single most important graphic to remember. I'm using it as my background as well. And here is the concept. How do we contain COVID-19? So imagine that we are trying to put a set of barriers, simple barriers, washing hands and masks. The other barrier that we have done is social distancing, or as we have safer at home, which the mayor has put together as a approach for us not causing the virus to go from one person to the other. But as you can imagine, and as you not imagine, but as you are experiencing, this is really hard to do. Are there ways that we can now go to the next step, which is the first couple of months, we had to do this to get the virus to be much more under control. Now we need to do targeted testing, symptomatics, those who are having some symptoms, and those who are not having symptoms, asymptomatic, doing targeted testing of them, isolation and quarantine of those who are positive, contact tracing, calling those who are positive of all of their contacts and keeping them and getting them to tell, and us, the health department, and even private providers, telling the patients to stay isolated, which is the whole process of the contact tracing, and then doing sentinel surveillance. And then last, but most importantly, the end game will be if we find an antiviral treatment or if we find a vaccine. And so to keep it in mind, this is the process we as a city, the county, the state, the nation, and the world is going through, each at its own pace, where we stop the virus through social distancing and safer at home and the lockdowns. Then we do an aggressive approach towards testing, isolation, contact tracing, and surveillance, and then the antiviral treatments and the vaccine we're hoping to get that will allow us to do it. I will mention testing. There are two types of tests. There is a PCR test that looks at the molecular virus, and that test is used to see if someone is infected at that time or not. The other is a antibody or serology test, and that test helps us see if you have had COVID-19 before and that you may be immune and you may be protected. And then last, how do we reopen? I'm on the task force with folks from the 4 other cities in Tennessee, the 3 other major cities. So there's a 4th city economic reopening task force. And we are having detailed conversations on how does one reopen the city. The governor has already said that the remaining other 89 counties, except for the 6 counties that have their own health departments and are in the major cities, the major cities are going to decide their own trajectory of when to reopen. And one way to look at it in broad conceptual framework is we have to balance our activities with what is going to be a risk, economic gain, and what our spiritual and social needs are. So just to give you an example, for example, the shopping malls, restaurants, which is a major source of economic gain if we reopen, and it's moderate health risk as compared to a social religious institutions is, some health risk, but more spiritual gain. And concerts, are a very high risk. That's where one person can spread it to 40 to 50 people. So with that as a background, I'll stop and have folks ask questions and open up for comments as well.
Thank you, Dr. Jain. That was excellent. I've already had a couple of requests online for, if at all possible, and if you're comfortable doing so, sharing the slides with us. I think people would like to review it on their own if they have questions.
Absolutely, yeah.
And there have been some questions that have come in. One that's kind of a foundational question that I think that might be useful for everyone is, what is surveillance? Can you talk about what that means, since that might not be a familiar term to everybody in regards to health?
Sure. So in going back to the core slide, I want to that I was sharing with you. Let me go back to this. So in the phase 2, which we're entering now, what surveillance means is looking at where there might be pockets of infection. So for example, what we need to do is targeted testing and surveillance at nursing homes. We know that there are outbreaks that can happen at nursing homes. And what we need to do is have the nursing home health workers there, as well as possible, sets of patients there, tested. And when we do these sentinel surveillance, we have a better idea of where there might be pockets of infection. And then we can take early and be proactive. And so that's what surveillance means, is we look at places where infection is likely to occur, and we test beforehand. Homeless populations, we need to do that, surveillance in those populations. So again, you do testing in those populations that are more likely to be at risk, and vulnerable populations also. I think you're on mute, Will. Yeah.
Thank you. There were a couple of questions from Dave Hale. I'm going to try to kind of combine them into one. Can you speak to, in regards to this containing COVID-19, is there a role for herd immunity?
Yes. So there is. So what herd immunity means is that a significant % of the population becomes infected and develop an immune response and develop antibodies. And then the infection is not propelled. And herd immunity requires is that 60% of the population should have either been vaccinated or have had the infection. Now, what we estimate in our setting, maybe 5 or at most 10% of the population may have had the infection, meaning in the past few months. In New York, it would be higher. Italy, obviously higher as well. But in our setting, now going from that 10% to 60% without a vaccine is a steep climb. And also imagine the same number of infections, if not more, and deaths would occur. Maybe a 6 to 7-fold number of infections. And so while herd immunity would be great, it will lead to a large number of people becoming sick and infected in the process. And what we want to do is avoid those illnesses and try to contain the virus. Good question.
Thank you. And then a couple of people have asked questions kind of in the tune of, what happened with our preparedness? Were we less prepared than we, as a nation, were we less prepared than we were led to believe? Someone referenced the previous rankings stated by Johns Hopkins, and someone's asked, what happened with the federal response as far as coordinating and distributing critical supplies?
Yeah. So I think the answer is very obvious from where we are today of our preparedness. also we can see our response of what happened in New York and what is happening in other places, even say Memphis and other places where we are much more prepared because we were able to see what happened in Italy and other cities. Sometimes it takes a lot of doing to be convinced that something like this is coming your way. We had a difficult time with the testing, and we've corrected a lot of that, and now testing is ramped up a good bit. We certainly could have done better. I can promise you this. I don't think anyone will cut CDC funding again. And I think this will fundamentally change, COVID-19 will fundamentally change our thinking about public health. No, just as 9/11 changed our thinking about our risk and our safety, COVID-19 is going to change what and how we think about public health. We have not prioritized public health. We have thought of it as more a stepchild. We have focused all our interest on curative health, but now we realize preventive health and public health are core elements of day-to-day wellness and good health. So those are lessons and opportunities that we have learned from this, and we really need to take those lessons to heart and make a difference. Otherwise, we will make the same mistakes again.
Thank you. Another question that we've had from a couple of folks is, what do you think will be the timeline for Memphis reopening, considering that Governor Lee has just stated that there'll be a kind of recent or soon reopening of the state at a state level, but he's leaving it up to the individual cities to determine what we do.
Right. So as we speak, there is a lot of work happening to figure out the timeline, the details, the step-by-step. I was on a 2-hour call this morning. I'll be on another call this evening in working out the details of what will work well with the cities. And it's been really a privilege to be able to participate and to provide expert advice. And I think the governor has been very collaborative in his efforts with the cities. He has allowed the cities to sort of make their own and best decisions in moving forward, understanding that their health departments are different, the characteristics of their makeup of population is different, and their trajectory for opening will be different as well. So we will see over the next week or two how that is going to play out. But clearly, we are going from that phase 1 to phase 2. It will be staggered, not everything all at once. And it will be based on metrics and benchmarks based on science, following and tracking the data, and then being prepared at any and all times that if things do not go right, that we need to pull back. And we know that we have been successful for social distancing, and then we have to, put that in place and then make a fresh new start if we have to, because we cannot incapacitate the healthcare system and allow the number of mortality and deaths to occur, morbidity and mortality to occur that we have seen in other places.
Thank you. Another question that's been submitted is, can you talk about the factors that complicate the virus or pre-existing conditions that seem to increase risk for higher levels of mortality or morbidity?
Sure. Yeah, so a good question in relation to clinical. So I'm an infectious disease doctor. We've been seeing a large number of patients. Our group has seen over 50 cases in the Memphis hospitals. And what we know, a few things, it doesn't cause complications in the young, very young, I mean, pediatric. But middle age and older folks, it can. and it causes a ARDS, or respiratory distress syndrome, acute respiratory distress syndrome, where the lungs aren't able to oxygenate. Now, it also probably causes a level of cardiomyopathy, meaning it weakens the heart. And that is a complication, and that probably is leading to death in people with underlying heart disease. So anyone who has underlying heart disease, lung disease, kidney disease, all of them, diabetes, all of them have greater complication rates and greater chance of death as well. And then it goes up significantly in the elderly as compared to those who are younger.
Thank you. I'm going to unmute everyone as best I can. And if anybody has an additional question that they would like to ask that they haven't asked, that we haven't asked already.
There have been at least reports in Maryland about that as well, of the racial disparity for COVID.
And then he came back because he said that
I may have misspoken. Hold on, I'm going to mute everybody.
Don't do that. Don't do that.
It looks like it's getting out of control. Hold on. And now you should be able to unmute yourself. I think someone was asking about racial disparities, but I'm not sure who that was. Was that you, Al? If you may have to unmute yourself if you want to ask a question.
It was me. It's Pam.
Pam, yes.
Dr. Jain, can you please talk about the racial disparity that is being noticed with regard to COVID-19? And is this happening in Memphis, particularly given our racial makeup?
I think it's happening all over the country. And we are seeing a larger percentage of African Americans who are becoming sick as well as who are dying from COVID-19. And there are multiple reasons. Some are biological or related to a higher percentage possibly being diabetes, heart disease, obesity in the population. Part of it may be the healthcare resources not being available to the population as well much as available to others. Part of it may be related to education and awareness that might not be there in the population. So when we mix all of those potentials, what ends up happening is that there may be, according to the data that we're seeing, a higher number of mortality and morbidity in that population. But that's not different, as you well know, compared to some of the other diseases. And we know that in terms of rates of amputation and complication, rates of breast cancer and complications. I think the most important first step was to have that data available and be aware of it. We weren't even tracking some of that data on race initially. So I think that's been very important. And then we should do, as we're doing, as the city is doing, is reach out into those populations to get tested, to increase awareness, so that the minority population we can do whatever is aware, and we can do whatever we can to help that population.
Thank you very much.
Dr. Jain, I think we may have one last question that I see now on the group chat, unless somebody else wants to submit questions there.
Mike's someone's got his hand up.
Yeah, that's Mike. All right, I'm going to stop with my question. I'll hold off on that. And Mike, I think you can speak if you want to.
On this chart that you showed, the comparison in 1918 of Philadelphia and St. Louis, the second bump, there's been a lot of historical saying that World War II ended in November and everybody went out and celebrated. Can you confirm or deny or add to? As an athletic director, I'm scared stiff that we'll go back to big football seasons and soccer and all these other major events. And
I know. So yeah, you're absolutely right. I am too quite afraid. Those large gatherings are a concern. And, you know, I wrote a piece last week or in the Commercial Appeal, and I said, I'm a big football fan. I grew up in Boston. I watched the New England Patriots. And I'm wondering what's going to happen. Well, Tom Brady's not there anymore, but still, I want to watch them. But one idea I sort of threw out was maybe what we do is we put fans in small, as whoever comes as a family, put them in clusters 6 feet apart. And you leave a lot of empty seats. But you do have some fans but they're socially distanced, far away. On airplanes, we put people, we remove the middle seat, or we don't seat people in the middle seat in ways that we can do it. We maybe take the players and we test them on a Thursday, and then and the coaches and everyone involved. And then if they're negative, then they get to play and be on the field on Sunday. So the new normal is what is going to be very different. And you are right that if we don't accommodate to a new normal, we are going to see a bump again. I mean, the virus is the virus and how it behaves. And we just cannot ignore the biology and the science that exist, the epidemiology. I mean, we can deny it as much as we want and stick our heads in the sand, but it will emerge in ways that we may not want it, but scientifically we can predict it.
Dr. Jain, that blends well into this next question from Rick, which was about, you know, a recent statement, I think from today, from the CDC director regarding the likely worsening of the situation in the fall and winter because it will overlap with the normal flu season. Yeah. Do you have any thoughts or additional comments on that?
Yes. So, you know, it gets very complicated when one has two competing viruses and you can't tell the difference between one or the other. We will be testing for both. We will be treating for both. And what will happen is the flu rates, I would suspect, are going to go lower than the usual in terms of cases and mortality because of the social distancing that we have learned, forcibly learned on how to do that. So the flu cases will be less. The real question is, by the fall, are we going to have some level of treatment that could be potentially available and early stages of potential of vaccine? And if there will be enough population, not to reach herd immunity, but at least enough immunity so that the transmission number, which is called the rho naught, which is what propels the epidemic, if that is at 1, the number of cases remain the same. If it's below 1, then the number of cases go down. And if that rho naught is less than 1, we can see the number of cases go down for COVID-19. And if the antibodies that we develop are sustained with MERS, or I believe with SARS rather, we found that the antibodies stayed for about 9 months. For other diseases like chickenpox, you know, it's lifetime immunity that we have. So those are all complications that and situations we are not sure about.
Thank you. I don't know that I've seen any more questions go in. I did have one question. I said Dave Hale earlier, but apparently that's Mark. Mark, glad you're here with us. About what are your thoughts regarding the drug combinations that have been kind of bandied about? I know we've gotten a little bit of conflicting information on a federal level.
I know. I mean, we have to follow the science. I know hydroxychloroquine has been touted at the federal level, and a recent study also came out today saying that it has not lived up to the expectations. We have a chain of interventions as infectious disease doctors and providers that we are using, beginning with the basic hydration, with fluids, with antibiotics. If we think there could be a bacteria infection, using steroids early on. We're also using hydroxychloroquine, Plaquenil, in case that may help. We don't know. And then using biologics, the antibodies for interleukin-6, that blocking antibodies, and then also plasma therapy from people who have had and have been cured and they have antibodies, and whether that can be utilized, and that's shown some success. And then obviously the ventilation and others. And all of that, I believe, is going to reduce the mortality rate. And at least in the clinical setting, we're seeing some hope in there.
Thank you. So I think we're at the end of the questions I've received on chat. Are there any other questions that you'd like to ask from the floor? If you want to show of hands, Mike was very effective in doing that. Seeing none. I did
Just an
again.
expression of appreciation.
Sorry, Pam.
I would
What was
just
that?
like to thank Dr. so very much for everything
Yes.
he's
Yes, thank you very much, Dr. Jain. We greatly appreciate your time and your work.
Well, great. It's truly a pleasure, and I want to thank Denise Bollheimer for all the work she has done with me and for decades and decades, and all the social work that she has done for so many years. So it's truly a privilege to be part of the group to share my ideas and thoughts.
We greatly appreciate your expertise and your time. Thank you so much.
Okay.
Before I log everyone off, I wanted to put my email in the chat address. I'll say it out loud too. My email address is wmcgriff@sco.edu. You can email me if you're not a member of the club. If you're interested in joining the club, we'd love to have you back for another test run. Or if you would like to, hold on a second, Al, I'm going to kick you out. There we go. Good. All right. So if you'd like to have any of the slides from tonight, I'll ask Dr. Jain to share those with us, and I'll send those back out to anybody who's interested in them. And if you have any suggestions for future speakers, we still are collecting those. I know I've talked to Charlotte Hoyle today from our club, and she and I are going to continue to work on arranging speakers for the coming weeks. As I said before, this meeting ID will remain active until we return to our normal time and place together. So again, 5:30 on Tuesdays, we'll be here on Zoom, and I hope to see you then. If not in Zoom, then I look forward to seeing you again in person. I hope everybody's doing well. Please don't hesitate to reach out to the club if you have any needs. If you just need to make a phone call and talk to another voice besides whoever's in your house, we'd be happy to chat. With that, I really appreciate y'all coming in tonight. Thanks to all our guests, and I hope you have a good evening. I'm going to end the meeting.
Thank you, Will.
Thank you.
Thank you,
Thank
Will.
you, Denise.
Denise, thank you for your efforts tonight.
Absolutely.
Thank you.
Thank you, thank you, thank you.
Thank
Good night, y'all.
Good night.
Susan, are you waving or are you logging out?
Oh, I was just drawing my fingernail polish.
Okay.
Quite frankly.
All right.
But I listened to every word.
That's why you were there. Very attentive. All
And
right.
it's frightening for us 65, 70 plus.
Yes. That's something we got to work on. All right. I'm going to hang it up now. I
Okay.
hope y'all have a great evening.
You too. Thank you, thank you. That's great.